Good afternoon, sir. Hello.
Hi.
Good afternoon, sir. Nikhil here, sir.
Good afternoon, Nikhil. How are you?
Yes, sir. Fine, sir.
Right. How many people have come so far?
Sir, 25 have come, sir.
25. Okay. One moment. Let me share my screen. Can you see my screen?
Yes, sir.
Okay. Now, while we are waiting for others to join, can you identify 3-4 people to be ready for answering? And give me the names.
Yes, sir. Yes, sir. Kashyap, you are there? Kashyap Patel? Mihir Rathod?
Yes, Nikhil.
Nihir. Okay.
Yeah, both are from Gujarat. Yeah.
Kashyap and Nihir. And who else?
Sir, one second.
Anybody from Chennai there?
Chennai, sir, 1 second.
No, I'm just asking like that.
Okay, sir.
I got to support the home team, no?
Yes, sir. Today, Chennai, no one is.
Yeah, they ditched me. Okay. Okay, then give me.
Rufus. Yeah, Rufus has come, sir.
Okay, Rufus.
Rufus, you are there?
Yeah.
Okay. One more person.
Yes, sir. Sumit Ramteke. Sumit. One more is Saurabh Dharia. Can you volunteer? Saurabh?
Yes, I'm there. Yes, I'm there.
Okay, we got Kashyap, Nihir, Rufus and Saurabh, the batsman. Okay.
Yes, sir.
Okay. Good. So, can we go? Or you want to? Okay, about 30 people have joined.
Yeah.
That's okay.
Sir, we'll start, sir.
We start. So, good afternoon, everybody. We have one more session now. I'm going to discuss a long case, and you're all adult cardiologists, so I expect all of the 4 of you to answer questions very well. This should be a fairly easy case for you guys, I expect. But let's see how the discussion goes. But it's a long case, so we have to finish that, and then we should have time for a few more slides. So we have to move fast. Okay. Right. Are you 4 guys ready? Hello.
Yes, sir.
Yeah, please respond immediately.
Yes, sir.
Otherwise, I can't see you, you can't see me. So I have to know whether you're listening or not. So whenever I ask something, please respond immediately so that I know that you're listening. Okay? Good. Now, so we have the patient, today's patient. Your patient is a 68-year-old farmer. He is a smoker, chronic smoker, hypertension on medications, regular medication, non-diabetic. Hello. Somebody's mic is making noise. Okay. About 2 years ago, the farmer had a few episodes of chest pain at rest. Some at rest, some during effort. It occurred over a period of 2 to 3 weeks frequently. and then he was hospitalized and treated. He was improved, and then he was discharged on medication. He's still taking medication. At present, his history is occasional chest pain, about once a month. It occurs when he carries heavy bags, when he go, and particularly when he climbs up a ladder with a bag. It subsides when he takes rest or he takes sublingual tablets. So because of this episode, he has reduced his heavy work. So he has employed some help. Therefore, he tends to avoid heavy, but still he is able to do all his routine work. Only that heavy lifting and all he is avoiding. He needs that sublingual tablet about once or twice a month. That's all. Okay, can I go to the next slide? Have you noted the history?
Yes, sir.
Okay. So his current medications are, he's got aspirin, atorvastatin, lisinopril for blood pressure, and sublingual nitroglycerin. He takes it whenever he feels he's having heaviness in the chest, or maybe once or twice a month. But he always keeps it with him. So physical examination, BMI 28, BP 136/76, and normal pulses, JVP, no cardiac enlargement, normal heart sound. So nothing spectacular on examination. ECG sinus rhythm, -15 axis, no ventricular hypertrophy, no resting EST T wave changes, and no conduction defect. Right? Echocardiogram, normal LV size, ejection fraction normal, no regional wall motion anomaly, and normal Doppler flow. And the basic blood test that the patient had was hemoglobin, mild some hyperlipidemia, normal renal parameters. Okay, so that's the workup of the patient. He had all this workup already done because he had trouble some 2 years ago, and then he's continued to be on follow-up. Okay, but now he wants a reassessment. Okay, have you noted this part? Can I go to the next slide?
Yes, sir.
Okay. Yes. Any questions on this? If you want to ask any clarification, you can ask. If you have no question, tell me no question. Hello?
Two questions, sir.
No question. Shall I go to the next slide? Okay.
Yes, sir.
So now he has come to you because he wants to know what is the problem, what is the plan now. What's your plan? Okay, one of you answer. Come on, Kashyap, Nihir, Rufus, and Saurabh. One of you. This is a bread and butter for you. No, every day you are seeing the cases in the OPD. Typical history, typical finding, and he is asking a very fair question. What is the problem? What should I do about it? Come on, what is your plan?
So there is a history of typical angina relieved by sublingual nitrates. So I will, and echo and ECGs are normal. So he has dyslipidemia also, and he is a risk factors like smoker, and he is hypertensive. So I would like to go with such stress exercise testing to rule out ischemic heart disease first, sir.
Okay, so I agree with your first point that first thing is you made a provisional diagnosis. That's the first part one of your assessment. Yes, so that you have done correctly. I agree with you whatever you said. So he has history of hypertension, smoker, history very suggestive of angina pectoris, no doubt about it, and a good LV function. But 2 years ago he had something slightly different. You don't want to comment on that now, is it?
Yes, 2 years ago he was having on and off chest pain, sir. Sometimes during effort also.
So that is also classical angina of effort, is it?
Yes, sir.
Okay, I'll come back to that later. Yeah, somebody else is talking.
If sir past admissions history or data are available, we can see why he was admitted at that time.
No, he doesn't have those. He has lost those papers. But this is a history I will give you. 2 years ago, he had few episodes of chest pain over 2 to 3 week period. Some episodes at rest, others during effort. Was hospitalized, treated, improved, and discharged.
Sir, as he is admitted previously, it should be an acute coronary syndrome even, maybe an unstable angina or NSTMI.
Yeah. So why didn't you say that? Why didn't you say that? I don't know who talked earlier. You only said angina pectoris. You never said that he probably started off with an episode of unstable angina. We don't know. It may be unstable angina. It may even be a myocardial infarction. We don't know. He had a few episodes of pain at rest. Pain at rest is not angina pectoris. So he started off with an unstable episode, but later on he settled down and became a classical angina pectoris. That's the diagnosis. So you want to do treadmill? That's what you said. Who said the treadmill?
I said, sir.
Mihir. Okay. Okay. So, but what is the aim of your investigation now? And you have to have an aim, no? Then only you plan the test. Simply saying treadmill is not doesn't help, because treadmill. Sometimes we do test because that's the test available in our hospital, so we do it. Is that the reason, or you have some specific aim?
Sir, to rule out ischemic heart disease, sir.
Okay, that's a very poor answer, no? You have any doubt about his ischemic heart disease from the history?
But the severity of heart disease,
okay.
We also
so that is different, no? The aim is to assess severity. The aim is not to confirm coronary artery disease, no?
Yes.
Do you have any doubt about that he has ischemic heart disease?
No, sir.
Then the history is very suggestive, very classical of angina. Therefore, the strong likelihood of coronary artery disease. But treadmill can help show ischemia, and it also shows to assess severity. So the aim is not to confirm coronary. The aim is to assess severity now. You should be very clear in your plan. Okay.
Yes, sir.
So what is functional class you haven't told? Would you classify as first class 1 or class 2?
Sir, he is on carrying heavy objects and stepping on ladder. So he is functional class 2, sir.
What is class 2?
So patient with cardiac disease who are having symptom like angina, dyspnea, fatigue and palpitation on more than accustomed activity, sir.
And what is class 1?
Class 1 is, sir, patient with cardiac disease and symptom of angina, heart failure, angina, syncope, palpitation on
fatigue, not present
on routine activity, sir.
Both are same, you are telling, no? You are saying the same thing for functional class 1 and class 2. You said symptom more than normal. Here you are saying no symptoms on normal activity. I think you are confusing. Functional class 1 is no symptoms on ordinary activity. But symptoms on more than normal activity can be there in class 1. Anybody who does supranormal activity can get symptoms. Even a cardiac patient, even a normal person. Class 2 is symptoms on ordinary activity. So this gentleman doesn't have symptoms on ordinary activity. Only when he climbs a heavy bag up the stairs, he gets pain. So strictly speaking, now he can call him class 1. Or if you say that climbing the ladder is normal for a farmer, then you can put him in class 2. Okay, he's somewhere in between class 1 and class 2, but you must be very clear about your definition. At this stage, you cannot confuse between class 1 and class 2 definition. Class 1 is no symptoms on ordinary activity. Class 2 is symptoms on ordinary activity. Class 3 is symptoms on less than ordinary activity. Class 4 is symptoms without activity. Got it?
Okay, sir.
Okay. So is he functional class 1 or class 2 depending on how you look at his normal activities?
Sir?
So, yes.
This patient is already had an MI and again having symptom, and again we are going to do a treadmill. It is not going to benefit us much way. So instead of doing a treadmill, it is better to do a nuclear scanning like SPECT, which will help us in detecting the viability and the percentage of myocardium involved. So we can go for the further.
How are you assuming that he had a myocardial infarction? I said he might have had, I said. How did you assume that he had myocardial infarction? I only said he has an unstable episode. Why can't it be just a new onset angina, unstable angina for a few days and then settle down? Can't it be?
Can be, sir, but he required an admission also, which was
unstable angina you don't admit. Angina of in the first onset angina you don't admit. They are all unstable angina, no?
Yes.
So I think treadmill is not a bad choice because it is a test which is available most widely in all the hospitals, even district hospitals, even private nursing homes have treadmill, and therefore treadmill is not a wrong answer, I would say. But I agree, treadmill is not the most useful test also. That part I agree with you. But somebody says you want to do treadmill, you can't fight with him. Somebody who has very little symptoms and who has got normal LV function and good effort tolerance by history, somebody wants to do a treadmill, I won't call it wrong, but it's not going to be very useful. Let us see how useful it is. We'll do the test and see. Anyway, there's no risk in doing it, so let us do it and see. The doctor who answered, Mihir answered that he wants. Dr. Mihir is a treating cardiologist, so we have to follow his advice. So he wants to do a treadmill, we'll do a treadmill. But let us, after a treadmill, we'll decide whether it is useful or not. Okay?
Sir, so 2 points I wanted to mention, sir.
Yeah.
So first thing is, when he was admitted, we didn't ask him for investigations, whether anything was done at that time. Like,
I know. He had everything, but he doesn't have it. He's a farmer, he has lost it. So we have only this information that is available.
Yes, sir. And apart from that, we should ask him for whether angiogram was done, or that is also one thing, sir.
No.
That we didn't.
No. He was only treated. No, he was treated by a private doctor, and he was in a private hospital. Nothing more was. Now only has come for a formal assessment.
Yes. So, sir, the second point is, in the history, sir, you have mentioned like he gets angina on exertion, sir. So I think treadmill will not give any additional information, sir, even functional class, sir, because he has already inducible ischemia is there, sir. He gets angina, sir.
Absolutely correct. I entirely agree with you. That is the answer I wanted. A treadmill can be done because there's nothing wrong in doing a treadmill. But he already has a definite history of inducible ischemia, and he's also telling you that he has to exert too much, very heavily to produce that ischemia. He's already telling you that. So I think treadmill has a very little role. But as I told you, most hospitals in India and in the world would have treadmill in there, and very often the patient gets a treadmill done even before the cardiologist sees the patient, isn't it? Most of the thing. Therefore, I think treadmill generally gets done, whether right or wrong. But I agree with you, a treadmill is not the most useful test here. And in the examination, you might have an examiner who would say treadmill is useless. You might also have an examiner whom, if you don't say treadmill, he may get very upset. So the smart thing is to say treadmill. Yes, sir, I will do treadmill, but because it's a very safe test, it can be done easily. But at the same time, it is very limited use. That is a smart way of answering. How does that sound?
Yes.
Yes. You have to be one up on the examiner. You have to tell him, look, I know all the answers, but I know you will confuse me. Therefore, I will say treadmill, and then I will say it is useless. Got it?
Yes. Yes, sir. Yes.
So that is the way to answer when you have a tricky question. Okay. So, but you must be very clear why you are working up. No, that I found missing in your answer. When you say treadmill, that answer is nothing wrong with treadmill, but you have not said the aim is not to detect coronary artery disease. The aim of not even to see exercise ST segment. We want to see the severity of coronary artery. That is our aim. The aim is to know the severity. Now, what is the best test to know severity? Is it treadmill? Well, we'll come to that again later. Okay, that is the treadmill. Come on, Mihir, you only asked for treadmill, no? He completed 12 minutes, no symptoms. That is the ECG at just after stopping.
So this ECG shows upsloping ST depressions upsloping ST depressions are there, and so sir, it is when completed 12 meds, so very low probability for coronary artery disease, sir.
Oh, come on, give me a report on treadmill. Yeah, don't go to conclusion straight away. See, you're not reported the treadmill and you went straight to probability and all.
TMT is negative for inducible ischemia. With good response to exercise, with 85%, I'm considering 85% target heart rate has been achieved, and he has completed 12 meds. That is good effort tolerance also. But the ECG suggestive of there is negative for inducible ischemia.
Okay, now that's better. No, that's better than saying straight away telling probability. Probability will come later after you report it. So completed 12 meds, no symptoms. You must mention no symptoms. That's very important. Normal blood pressure response. There was oblique ST depression, but it was not significant, less than 0.5 millimeters at peak exercise, and the changes subsided immediately after stopping exercise. So the treadmill was considered negative. What next? Anything else you can conclude from treadmill? These things you already said.
Sir, yes, sir. One more thing I just wanted to ask. Post recovery, we normally take at 2 minutes and 5 minutes.
Yeah, we've taken all that. There's nothing.
Yeah. Okay, sir. That's it.
Okay, you happy with treadmill? Shall I go to the next slide?
Yes, sir.
Yes, sir.
But you don't want to conclude anything more from treadmill? That's all? See, we have discussed treadmill about a few weeks ago when I discussed the interactive case, and I told you a lot of details about treadmill. You're not... Okay, now you can tell me, what do you think about the severity of ischemia from treadmill? Just not severe, only two categories. There's no need to tell me 20%, 30% and all.
Not severe, sir.
How did you conclude?
Because, sir, he achieved 12 meds and without any symptoms, and no inducible ischemia on, no ST depressions are there, sir. On peak exercise also and in rest recovery phase also.
Okay. That was Meher.
So
What about
sir, BP response? BP
response was normal.
It was normal. It was normal.
Systolic rise, normal systolic rise, and came back normal. There's nothing but normal as expected. Nothing wrong. So anybody else has a different opinion on severity of ischemia? Come on, one of the other three people. Do you all agree with Meher? Say yes quickly.
Sir, it is the TMT information gives us that there is less likely that patient will be suffering from severe coronary artery disease. Either or it will be maybe some like vasospastic or spasm which may causing him the ischemic symptom.
No. You're now concluding too much. I'm just asking you, does it give any clue to severity? I am afraid I don't agree with you. You should go back and look at my talk in month of May when I discussed a patient with positive treadmill. A treadmill is useful to diagnose severe coronary artery disease like left main or three vessel disease if the changes are present: marked ST depression, very early ST depression, prolonged ST depression, hypotension, failure to rise the BP and all those things. If those changes are there, it indicates severe coronary artery disease. But if those changes are not there, it doesn't rule out severe coronary artery disease. Do you remember that I told you?
Yes, sir, we have discussed that case.
If severe changes are present, it is helpful to diagnose severe coronary artery disease. But if severe treadmill changes are not present, it does not rule out severe coronary artery disease. There is a difference between two statements. Do you understand? Do you understand?
Yes, sir.
Yes. So, I think your answers were wrong. This treadmill does not give any indication for severe ischemia. I agree. But that doesn't mean that the patient cannot have severe coronary artery disease. Okay? Hey, you're taking too long to respond.
Yes, sir.
Okay. There's something called Duke's index. Nobody talked about it. Why don't you at least talk about it? These are all things examiner is always watching for now. What is the Duke score in this case? I told you 12 minutes, 0.5 millimeter ST depression.
It's more than 5, sir.
So, what does it mean?
It means
score
low risk.
Score is 9.5. So, the Duke treadmill score is also indicating low risk.
Yes.
Again, if the score is high risk, it is important. A low risk does not rule out coronary artery disease. Please remember that. Okay?
Okay.
And once again, I am reminding you, treadmill is not just about ST depression. You have to take into account all these factors before giving an opinion on treadmill. Okay? And your report should contain a word about all these factors. And this is also a repeat slide from the last talk. Okay, now what is your advice? Okay, Mihir, you asked for treadmill, no? Now what is your diagnosis or what is your idea of coronary artery disease? What is your idea about risk category and what is your advice?
Sir, CAD cannot be ruled out, and risk is low because he has completed 12 months without any symptoms and without ECG changes. So risk is low.
Okay, so now what is your advice?
Critical management.
Sir, we can go for on treatment on basis of stable ischemic heart disease, sir.
What is that?
So, sir, he is already taking aspirin, antiplatelets. He is taking already. So we can give him nitrates and beta blockers for angina, sir.
Okay. Everybody agrees?
Control lipid profile.
Sir, other type of risk.
Yeah, lipid profile already done. No, I showed you.
No, to control, treat the.
Yeah, control. Agreed.
Sir, other risk stratification strategies we should do.
What is that?
Like myocardial perfusion study or invasive angiography for risk stratification. Only TMT we have done.
Why the treadmill is negative?
But
Negative
treadmill is sensitivity specificity for invasive angiogram will be more, sir. Than
I want a better answer. I discussed all this in detail in the month of May. All this I discussed. I'm discussing it again. No? Nobody's answering? Anybody from the audience?
Sir, we can start with the anti-anginal treatment and observe our patient for a while. If he's still having angina without the maximum anti-anginal treatment, we can go for a coronary CT angio or coronary angiogram and look for whether he's having ostial LAD or LMCA disease. In that case, according to ischemia trial, those patients to be further.
So you decide this ostial LAD or your LMCA disease based on the symptoms, is it?
No, sir. First we'll.
That's what you're telling.
No, sir. Even after this treatment, the symptom persists.
But suppose he is having left main disease now and you're treating, is that correct? I don't know what you're saying.
No, sir. After giving the anti-anginal treatment, even after the treatment.
He has already been taking for 2 years, man. What do you mean after? He has already been taking for 2 years. He has come after 2 years of anti-anginal treatment.
So then we have to go for invasive procedure like coronary angiogram or.
Again, why coronary angio? You are not making a justification at all. You are not giving me the right answer, no? Because if I am an educated patient, I am not convinced by your answer. I am not convinced by continued medical treatment. I am not convinced by your advice of angiography also. So you are not giving me confident answers.
The pretest probability for CAD is quite high.
Okay, now that sounds. Who's that? Hello. Hello.
Yes, sir.
Hey, come on. Who was that who talked about pre-test probability and all?
Sir, Dr. Om Prakash.
Is he there or not there?
Yes, sir.
Okay, go ahead. So what did you say about pre-test possibility? Very good. Come on, continue.
Sir, if the age is more than 60, 60 to 70, and patient is having history of typical angina, then patient is having high pre-test probability for coronary artery disease.
Excellent.
As per his age, sex, and symptoms.
Okay.
So we have to, and the negative TMT doesn't rule out the presence of CAD.
Excellent.
So we have to proceed with the conventional angio.
Okay, conventional angio, I don't know, but you have to proceed with some tests. I agree with you. Okay, that's a good answer. That is the answer I was waiting for. Didn't I tell you last time? There's a very important point. The usefulness of the treadmill depends upon the pre-test probability. What is the probability of this gentleman having coronary artery disease? Now, this gentleman is 74 years. He's having hypertension. He's getting hyperlipidemia. He has a classical history of unstable angina initially and then stable angina. Therefore, it's a very high probability of coronary artery disease. When you have a high probability of coronary artery disease pre-test, a false positive test is very less likely, and a false negative test it happens. If the test is negative, it is very likely to be false negative. If you have a negative test, do not pay any attention to that, because a negative TMT does not rule out coronary artery disease in a patient who has got high pre-test probability. If the probability of coronary artery disease is high, a negative TMT does not rule out coronary artery disease. It needs further investigation. Be very, very suspicious of a negative test. On the other hand, if you have an asymptomatic patient, that means a low pre-test possibility, then if you get a negative test, it's probably likely to be correct. But in this setting, a negative test is not likely to be correct. And therefore, when you get a negative test, you need always further testing. If you get positive, you need further testing. If you get negative, you need further testing. Therefore, in this gentleman with 74 years, hypertension and angina, whether you get a positive TMT or whether you get a negative TMT, you have to quantify coronary artery disease. Therefore, a treadmill is not very useful in this. Now, do you understand why I was not agreeing to treadmill in the first place? I know everybody does treadmill, but treadmill doesn't help, because if it is positive, okay, so what? I knew about it. I knew it will be positive. If it is negative, I still don't pay any attention. I will still do some more tests for coronary artery disease. Is that understood clearly? This is very important.
Yes, sir.
Okay. So we need some more tests. This is not enough. A negative test doesn't mean anything. So what is your other steps? We've got so many tests available now. No? In fact, there are maybe some more also have missed. Okay. So we have so many tests. I think many of your hospitals must be having this. Stress echocardiography, perfusion scintigraphy, stress scintigraphy, CT coronary angiography, calcium score, coronary angiography, MRI angiogram, heart and coronary, PET scan. So now come on, tell me, which one will you do amongst these?
Perfusion scintigraphy, sir.
Perfusion scintigraphy. So what exactly do you mean by perfusion scintigraphy? You mean thallium scan?
Yes, sir.
Okay.
Thallium
what information do you expect from that?
We will know if there any area of ischemia is there or not. We will get information, and we can get the amount of area involved. If the amount is more than 12%, we can plan for revascularization, or we can otherwise.
What do you mean amount of ischemia? He doesn't have any ischemia at rest, no?
No, we can perfusion means we can do both rest and stress, sir.
Then you have to tell them this one. No, why are you talking about this? This is the one.
Okay.
Simple thallium scan will not.
Option.
Come on, now, the slide is in front of you. If you don't see it, whose fault it is?
Sorry, sir.
So, simple scan with thallium will not give you the answer because there is no resting ischemia expected in this patient.
Yes, sir.
Okay. Scintigraphy with stress is a good test because it will prove you whether there is ischemia on effort. It will also give you the amount of ischemia. I agree with you. What about stress echocardiogram? Is that a good test?
No, compared to
Yes, sir.
Okay. What about coronary calcium score? Will you do that?
No, sir.
Not in this case.
Why not?
So in high
Already there
probability
is a
cases, does not very useful.
Okay. So we already have know that he has coronary artery disease. There is no calcium score is more of a screening test to confirm presence of coronary artery disease. It has nothing to do with severity of coronary artery disease. I agree. What about CT coronary angio?
Sir, probability is already high that patient has coronary artery disease. So we can straight away we can avoid this test in this patient.
Okay, good. So CT coronary angio is done only if the probability is medium or low to confirm the presence of coronary artery disease. Since the probability of coronary artery disease in our patient is very high, we would rather go for direct quantification rather than doing one more test, because anyway this doesn't give you information about the area of ischemia, how the complete details for needed for PCI or surgery and all that doesn't give you. Therefore, there's no point in doing either calcium score or CT coronary. Stress echocardiography is a little cumbersome test. Not every hospital is equipped to do it. It also gives you some evidence of the amount of myocardium involved. Yes. So I think as a general principle of quantification of area involved, maybe stress or stress echocardiography or stress scintigraphy may be done. Stress scintigraphy is slightly better, probably. Of course, the MRI has very little role in assessment of coronary arteries. It does give you good information of movement of the wall segment, but it has very little role in them. And PET scan is, I don't think we really need for the initial evaluation. Therefore, our choice is between, depending upon the hospital and what facilities you have, you could do a stress scintigraphy, you could do a stress echocardiography, or you could go directly for coronary angiography. There may be some hospital who may even skip a treadmill and go directly for coronary angiography. I have no problem with that. You can, because we want a quantification of coronary artery disease. But mind you, you must separate a diagnostic coronary study from intervention. They are two different things. Okay, we are talking of only diagnostic coronary angiography now. Okay, so
Sir, in some studies they have shown that dobutamine stress when performed with MRI has got very high sensitivity.
Yeah, but you know how many hospitals can do MRI with dobutamine stress test? Do you know?
Yeah, the availability is less.
Yeah, then that's what I'm saying. What is commonly available, what is easily done, what is less expensive, that we should think. If you do MRI with dobutamine and all that, still you have to come back to coronary angiography?
Yes, sir.
Then whose pocket is my money is going? So which one will you choose now?
Sir, one doubt, sir, before.
Yeah, tell me.
Sir, as we have discussed, like when he was doing a treadmill, he was under stress only, like he walked for 12 minutes. So in stress echo and stress test also, we are going to do the same only. Like he will be able to tolerate, there will be no symptoms.
No, there is a difference.
Okay, sir.
Treadmill is limited by symptoms, whereas dobutamine echo and scintigraphy is objective evidence of area of ischemia. Symptoms and area of ischemia are two different things. A patient may have a large area of ischemia but no pain.
Oh, okay, sir. Okay.
A patient may have severe pain but have very little ischemia.
Okay, sir. Okay. Yeah,
You get the difference?
Yes, I got it, sir. Imaging is the main difference.
So you have the choice of doing stress echo or scintigraphy, or you could go directly for coronary. Maybe I guess most of the hospitals in India probably by the time you and me are talking, they would have finished coronary angiography. That's what I think would be happening. I mean, I don't mind that doing coronary angiography as long as you clearly differentiate coronary angiography from the next step of intervention. Angiography should not automatically lead to intervention. That is all it is. But as long as you know why you are doing a test, I have no problem with doing coronary angiography. Okay? Okay. So this patient probably went for when this doctor who treated, I don't know who it was, maybe Mihir, you advised coronary angiography. Now I'm not going to show you the full angiogram because it will take too much time. I'll just show you still frame, and who is going to describe it? Mihir is going to describe it. Okay, two views, one of right coronary artery, one of left coronary artery. I'm only showing you limited views. Come on, quickly tell me what you see.
So the upper image is right coronary artery, sir. Right coronary artery showing mid part there is a moderate stenosis is there, sir. And there is a left angiogram. LAD is showing LAD after first diagonal showing the diffuse long segment involvement of disease, sir.
Okay. Are you done?
Yes, sir.
Okay. Does anybody else want to add something or ask something?
So distal RCA is occluded, filling retrogradely from LAD.
Distal RCA? Where is it occluded? Even this one's all filling posterior descending posterolateral.
Small branch.
This one you are talking?
Yes, sir.
No. Actually, it's a type 3 LAD going around the apex. This is not the RCA. The RCA would be somewhere here. I'm sorry, it's a limited view, so I can't. Okay, I want to add anything additional to the findings, that's all I'm asking. All four of you agree with that description?
So the upper segment is a LA view of RCA, has got a mid segment around 70 to 90% disease. And the lower part, the left main has got some plaquing. And it's a cranial view, probably PA cranial view. And mid segment has a mid to distal has got a long segment diffuse disease, maximum of 70 to 90% in the mid segment. And diagonal as well has got some disease, but diagonal is a comparatively moderate sized vessel. Caudal view, I need a caudal view to assess the LCX as well, sir.
Okay, for the time being, you assume LCX is normal. Okay.
Okay, sir.
Okay.
Who
was that the second person who described the angio? Anyway, whoever it
Amazon,
was.
sir.
Amazon, okay. Amazon is slightly better than the first person, but I'm quite disappointed with the way your people have described an angiogram. You're all supposed to be adult cardiologists, supposed to be describing coronary angio every day, but I'm very, very unhappy about the way you have described a coronary artery disease. Don't you have so many points to describe in a coronary artery? Size of the coronary artery, the type of coronary lesion, whether there is calcification or not, whether the distal flow is good, the size of the distal artery, whether there are any collateral, whether the distal vessels graftable. So many the details you are supposed to give. How to report a coronary angio is very, very important. Most important, you must ask me whether there was any calcification or not. Nobody asked me that. If you had asked me, I would have given you this information. There was calcification. No, your description of coronary angio is totally incomplete because the coronary angio is being reported not to just produce a piece of paper for the patient to carry home. The coronary angio is being reported for you or any other doctor, surgeon or cardiologist to have a mental impression of the coronary artery in that patient and also to plan management. Without that information, your report is totally incomplete. Do you know, then I heard one person saying moderate stenosis, another person saying 70 to 90% stenosis. What is this 70 to 90%? How do I know? Is 70% important or 90% important? Or is moderate means what? 50%, 45%, 55%? What is important? I don't think that's the way angiogram is reported, no? And do you know why we are reporting diameter? Are you reporting diameter or are you reporting cross-sectional area? When you say moderate and when you say 70 to 90%. Generally, when you calculate a 50% reduction in the diameter, 50% when you say, it is 50% of the normal segment of the artery, okay? When the diameter falls at 50%, the area is already reduced by 75%, right? Now, why this 50 to 75 you can calculate? Because there is a formula for converting diameter into area, or area inside. So you can calculate and see, and then you will know how the 50% diameter corresponds to 70% reduction in area. A 70% reduction in diameter, that means 70%, here it is 10 millimeters, here it is 3 millimeters, that is 70% reduction, amount to 90% loss of cross-sectional area. If you have 90% loss, that means 10 millimeters here and it is 1 millimeter, so 10 millimeters become 1 millimeter, then it is 99% loss of area. Now, why these figures have been given is 50%, 70%, 90%, because most of anybody don't actually sit down and measure the coronary artery. Nobody ever measures the proximal coronary artery, nobody measures the stenosis. They always give a rough eyeballing. Now, eyeballing, you cannot say it is 55%, 65%, 75%, 85%. And you should also not say 70%, 90%. Roughly, you should say it has to fall into one of these categories. Less than 50%, 50%, or 50 to 70, 50, 69%. 50 to 69% would all be called 50%. 70 to 90% would all be called 70%. And 90 to 99 would all be called 99%. 90%, sorry. 99 and then 100%. So these figures are given just for rough eyeballing, which is what we do most of the time. So don't say 70 to 90%. You have to say either 70% or 90%. You cannot say that's the way to report it. In addition, there are gross errors in reporting. For example, I'll show you what is the error. Now 1 second. So if you look at this, I'm sorry, I should have hidden this slide. One moment. I shouldn't have shown you that slide by mistake. Let me. Okay, it's all right. I can have a look. See, for example, this. If you don't look at this, your rough estimate here would be: is it less than 50% or more than 50%? This one. This is a normal artery. This is the stenos segment. It is less than 50%, isn't it?
Yes, sir.
Yeah. So it's correct. Actually, when you measure it by calipers, it's only 33%. This would approximately look 50%. If you measure this, probably half of this. So approximately what? The milder degree of stenosis, your eyeballing is always more or less correct. But when you come down to more severe degree, can you see this? What percentage would you expect this to be of this? I would have said about 80 or 85, 90%. That's what my guess would have been. Actually, when you measure this, it's only 70%. And this, I would have called it probably more than 99%, I would have called it. But it's actually only 85% when you actually measure it. Because angiogram has its own limitation. Because of the X-rays coming through, it would always give some disparity between the actual dimensions and your estimated value. Therefore, eyeballing has its own drawbacks always. Therefore, you must stick to whether it is less than 50%, 50 to 70%, 90% or 99%. You stick to only these 50, 70, 90, 99. That's all you have categories. There's nothing in between. Now, when you come to that, what would you call this here? Would you call it closer to 70 or closer to 90?
Closer to 70, sir.
Okay, so say that.
70.
Okay, what would you call this? Closer to 70 or closer to 50 or closer to 90?
90.
You think this is more severe than this?
No, 70.
Yes. I would say this is also around 70, this is also around 70. This is a smooth stenosis, whereas this is a very irregular, elongated stenosis. Therefore, between these two stenosis, I think this is more severe. I think this much, no, you haven't described the type of disease. This is a much shorter segment, this is a much longer segment. So, I would guess the coronary artery disease more in this angio than in this segment. So, there are so many things you have not described in the coronary angio. So, I have no doubt this coronary artery lesion is severe because it's long, it appears to be at least 70% or more, and it is very irregular and calcified, I know that. Therefore, I would expect this coronary lesion to be quite severe. This I am not so sure. It's a very short lesion, very smooth artery otherwise, and it still qualifies for a discrete lesion, and no calcification has been described. It's an absolutely straight vessel. There's no curves or bends. Why that is important? Because if I want to do any intervention, all those things are important. Now, when you come to severity, you don't say mild, moderate, severe, unless you know what is moderate. If you know what is moderate, then you use the word. But otherwise, you have to describe. If you use moderate, you must tell me what percentage it is. Therefore, we always say anything less than 25% is called normal. From 25 to 49% would be mild, which most of the time we call it plaques. Anything from 50 to 69, you may call it moderate. 70 to 99 would qualify as severe. And of course, 99 or more is called as occluded artery. If you use mild, moderate, severe, you must have very clear concept of what lumen size you mean. And this all applies to diameter, not to area. Okay? In addition, you must always talk about calcification, present or absent. Okay?
Hello?
Yes, sir.
Yes, sir.
Yeah. Now, you are all learning PTCA left and right, but you are not describing the type of lesion. Don't you have to describe the type of the lesion, type A, type B, type C? I am not going to tell you what is type A, type B, type C, you already know it. But you don't describe it when you are describing a lesion. Your American Heart Association, AHA classification of type A, type B, type C. The RCA lesion is what? Type A or type B or type C?
Type A, sir.
Type A. And what is a LAD lesion?
Type C.
What is the importance of this classification?
The success of the procedure can be taken from this.
Yeah. Yes.
Yes. 1%, please.
The probability of the success of the procedure can be determined by the type of lesion.
So difficulty and prognosis of the procedure can be predicted. Therefore, it's very important to describe it because you are diagnosing two-vessel disease and you are not talking about the lesion is very important. So we have a type A lesion of moderate 70, possibly 70 stenosis in RCA, and we have a definitely calcified severe lesion in LAD. Okay, type C. Okay. So what is the diagnosis now? Come on, quick! Don't waste time. We'll run out of time. Other we won't even finish this case. Don't think any case is simple. In the exam, even a coronary artery disease can be as a long case, and this long case is going to continue for 1.5 hours now. Okay, what is the diagnosis?
Coronary artery disease, double vessel disease, systemic hypertension, smoker. Okay,
all that will not repeat. Two-vessel disease, chronic stable angina. You should utter that word. There's a difference between unstable angina and stable angina. So I always say chronic stable angina. And then good LV function, good effort tolerance, favorable TMT result. Okay, then you agree with this? Tight type C LAD disease in a type 3 LAD.
Calcification. Yes, sir.
With calcification. And moderately tight. I have some doubt about the severity of RCA. Moderate, I would say, but I don't know. Moderate is what? 70% or less than 70%. Mid RCA lesion, type A lesion. Okay?
Okay.
Okay, now what? Come on, quick. These are all everyday problems. What is your advice? Because these are all everyday problems.
Functional assessment.
What functional assessment? LV function.
No, sir. FFR, should we think about fraction flow results? Since it's a borderline lesion we are describing.
So you're worried about RC?
Yes, so both the...
Which lesion or borderline you're talking?
Sir, both are borderline, sir.
But why borderline? I thought LADs, we agreed it is tight and type 3, type
yes.
C and all that. What is borderline about LAD?
Yes, sir.
No, no. Don't withdraw your answer. I am arguing. You have to answer me. Don't withdraw your answer.
Okay, sir.
Why do you say LAD is borderline?
Sir, there is no...
Anybody else? Why do you say LAD is borderline? Come on. Anybody else? Rufus, Saurabh, Amudan?
It is severe, sir. It is severe. Definitely severe disease in LAD, sir.
Okay. So you think it is severe? Okay. So what is your advice now?
Yes.
So now we can do syntax scoring, sir.
We can do, no, you should do, not me.
Yes, sir. We have to do syntax scoring. If the score is more than 32, we have to advise surgery.
Okay. Any other advice? Any other viewpoint? Come on, syntax corridor. You should do roughly. Syntax corridor you should do roughly in your mind and tell me. You can't say I will do it later. You're on the cath lab table and you have to decide what next. Okay.
Sir, I think LAD lesion is not severe, sir.
Why not?
Moderate. Because the proximal LAD is disease free, sir, and the disease starts from mid only. The amount of jeopardized myocardium will be less, sir.
Very good. That's the answer I wanted. But don't tell me disease is not severe. Disease is very severe only, but the location is in the mid LAD, not in one big diagonal and one septal has already come off from the LAD.
Yes.
Guys, other guys, what are you not seeing that? The location of the lesion is very important. No, it is not severity alone. The LAD may be big, it is a severe disease, but it is after a big septal and after a big diagonal. So, do you think mid LAD disease is the same as proximal LAD disease?
No, sir, definitely not. But it is the type 3 LAD, so it is reaching up to the apex. Then definitely it has to be treated, sir.
No, that is your view. You have to prove it. You cannot say, yeah, I agree. Some people would have done it straight away, but I want you to be scientific about it. So, this is not a proximal LAD disease. Okay? And this is a mid LAD disease after major diagonal and major septals have come off. Therefore, even though the disease is severe, I am not sure how much myocardium is at risk. What about the RCA lesion?
RCA lesion, borderline, sir.
Borderline. So what do you do now? What is your advice? You have to go to the next question. What is your advice?
As Nikhil said, sir, or we are in cath lab, we can definitely assess IFR and FFR. If it is significant, then we can think about treating it. If not significant, then we can leave it, sir, on medical management for RCA lesion.
So what do you want to assess? You clearly tell me. What is that you want to assess? What is a scientific term for that?
Physiological significance of the stenosis.
Yes, physiological significance of this coronary stenosis. Okay. Assess the significance of the RCA. Now, I have no doubt the LAD lesion is significant, but I have some doubt about RCA lesion. Therefore, I want to assess the significance of the lesion. So, how do you assess the significance of this lesion? What further assessment can you do? Okay, you are on the table. What will you do? You can do all this. Which one would you choose? Which one would you choose?
FFR, sir.
Why not intracoronary ultrasound?
It is not going to tell about the severity, sir. It is just going to tell about the flag, the pattern, and is it everything.
Yes, very good. So intracoronary ultrasound more useful for knowing the structure of the wall. It also useful in when deploying a stent, whether the apposition of the stent is good. So it is not virtual. What about OCT imaging? Would that be better to know the significance of the lesion?
No, sir. It is also going to show the same thing, except we can show the vulnerable plaque in the OCT.
Yes. So OCT imaging also doesn't tell you physiological significance. What about coronary flow reserve?
It will tell about the microvascular disease.
Yes. No, why did you say coronary flow reserve and not? Why did you say fractional flow reserve and not coronary flow reserve?
Now we have to see the
FFR
macrovascular.
One person, please. Any one person. Yeah. Why would you choose FFR and not CFR?
Sir, we have to do the macrovascular. We know already the severity is in the macrovascular vessel. We have to know the severity of the macrovascular vessel at the beginning.
No, I think a fractional flow reserve is a much easier thing to do. Very simple way of measuring ratio of pressures proximally and distally. Coronary flow measurement is a much more elaborate setup you need. It's not easy to do flow measurements in the coronary arteries. So you read a lot more things. Most lab will not be able to do CFR. FFR is a much easier thing to do, and all of you, I hope, know how it is done. Okay, and I'll come to that. What about IFR? Would you do IFR?
It's same like FFR, sir, but only adenosine we are not doing.
Okay, so what is which one would you choose? FFR or IFR? Which one is better?
FFR, sir, because it has many studies are there more with the FFR compared to IFR.
Okay. So IFR is done without any adenosine vasodilatation. People are reporting now that IFR can also give useful information, but as of now FFR is a well established one, and therefore for the time being FFR remains the test of choice. Since you are already on the CAT table, you probably put a pressure wire, and I won't go into telling you how to do a FFR because that you read up. So you have done a FFR study for this patient, but having put a wire, you will check both the arteries. Now, why check only RCA and not the LCA? So we decided to check both these things. Okay, all of you know the principle of FFR, no? So in a normal coronary artery, you have a pressure here, and as you go down the track, the flow goes into the smaller arteries. Now, in the presence of a plaque, there is a pressure difference in the proximal artery and the distal artery. When you give adenosine or exercise, the distal vessel dilate maximally, and therefore the capacity of the distal circulation increases markedly and the flow has to increase. But since the vessels are dilated and the flow has to increase, but the stenosis is significant, the gradient is accentuated between the proximal segment and the distal segment. Okay? So FFR measures the relative pressure in the proximal artery and the distal artery, whereas CFR measures the flow before and after vasodilatation. Okay, that's what is shown here. Normally it should increase on vasodilatation. When there is a stenosis, the flow cannot increase. This is CFR. Whereas the pressure measurement is much easily done. So see, we have done an FFR now. So that is the FFR in LAD. Who can interpret it for me?
Sir, it's positive, sir. FFR is positive.
No. Explain the slide to me, man. Don't go positive, negative.
Waves.
Please, I'm not telling you. The examiner doesn't like one-word answers. Tell what.
It is showing the distal and the
You have to show off your knowledge to the examiner. This is a chance for you to show off your knowledge. You must say what is happening, what has been done here, what is step by step you analyze it. Tell me.
It is showing the distal and the proximal pressure, sir, in the LAD before and after the lesion.
Go on.
And it is going the ratio of the distal and the proximal pressure, that is 0.64.
So what does it mean? 0.64.
Yes, sir. That is positive, sir.
After giving adenosine.
I think your description is totally incomplete. No? So first they have recorded both proximal and distal pressures, and before that there are some steps, equalization, zero checking and all that. Then adenosine has been given. The moment adenosine is given, the pressure between the proximal coronary artery pressure rises transiently, whereas the distal pressure actually drops. Therefore, the difference between the proximal and distal pressure widens out. Adenosine lasts only for a few seconds, and after some time, the difference comes back to its normal. Therefore, this is the once adenosine washes out, it's back to normal. That means this signal is genuine; it's not an artifact. So the normal ratio is, what is the normal ratio?
Normal is 1.
More than 0.8, sir.
Normal is
No, in the normal artery should be 1. When there is no 1, it should be 1. It is not 0.8. But most of the time you do FFR only in lesions which have atheroma already. Therefore you get ratios of less than 1. Anything more than less than 0.8 is considered a significant obstruction. So is the LAD obstruction significant?
Yes, sir.
Yes. So
Yes,
that has confirmed my impression of LAD being severe. That's the RCA.
Yes, sir. Sir, that yellow line, sir, what it is, sir? I didn't get, sir.
That no, some monitors give the point of injection and then time and don't worry about that. Yeah.
Okay, sir.
Okay, next one, RCA lesion. What is the interpretation?
RCA is not significant.
Yes, sir. RCA is not significant.
You can see that even after adenosine was given on this line, there is no widening. That means that lesion is not significant. Why does it appear stenosis there? Maybe the other view it is fully open. Maybe therefore it's nowhere near 70% clearly. Okay. So now we have RCA disease not significant, LAD disease significant. That is what we expected. What is the plan now? Again, every time I ask you a plan, you must update your diagnosis. You are not doing that. RCA is not severe according to FFR. LAD lesion is significant. That is updated diagnosis now. Okay? So, okay.
Yes.
Now tell me what is your plan for treating LAD, or do you need any more information?
Sir, we can do see the area of geopathy.
We can do many things. I don't want that. I want to know what you want to do. Don't never say we can do. That's not a good answer in exam.
Since the FFR is significant for LAD, sir, we'll go ahead with PTCA to LAD, sir.
So immediately you will proceed and do LAD angioplasty. Stent it.
Sir, after consent and explaining, sir, to the patient.
Yeah, of course we do that. But you are convinced, and you will stent it also, of course.
Yes, sir.
And maybe you will need a rotablator also because calcified disease. And you will need a 35 millimeters or 40 millimeters stent.
Yes, sir.
So anybody, other people have any different opinion, or you all agree with him?
So this is stable ischemic heart disease with single vessel disease. So first, optimal medical management we should do.
Now we have two extreme opinions, India and China. One side I have immediate stenting and rotablator with a high risk procedure. The other side you have medical management. How do I decide now?
Yes, sir. We have proven, sir, that LAD lesion is significant, sir. So optimal medical management won't come in this scenario, sir.
Okay. So what do you say to that medical management guy, whoever it is?
We should not do, sir. Even if it comes,
this is a debate, TCT we have debates. That's good.
Yeah, sir. Even if it comes in ischemia trial, sir, but the ischemia trial, one thing people are forgetting that people who are on medical management, the 20-30% there was a crossover to ACS, sir. So that people, that was a controversy, sir.
Okay, don't go to a big trial. The examiner,
yes.
You have to discuss in day-to-day practice. I know big things you will all answer, I know. But if I ask you, how will you classify bifurcation stenosis, how will you stent a bifurcation, all that things you will know, I know that. But day-to-day things, if you know, that is what I consider a good cardiologist. Okay. So how do we decide? Do we have a third umpire there? I had two opinions. I need a third umpire now.
Sir, one more thing, sir, I forgot to mention. He's a farmer, sir. We have to, I don't know, we have to consider the financial.
He has he's 74-year-old. He has already employed help. I told you in the history.
Okay, sir.
If you want any more information, I'll give you. Any third umpire there?
So amount of myocardium ischemic that we should know.
Okay, good. See,
yeah.
LAD lesion, everybody knows is severe. How does it matter? Even if a distal LAD is disease 90%, it is severe. Even if a tiny little septal artery is disease, it is severe. How does it matter? It all depends upon how much myocardium is ischemic. It doesn't matter what is the severity of coronary stenosis. Do you treat a coronary artery disease based on the severity of the lesion? We don't. Severity of lesion and all is only if the myocardium supplied is important. Otherwise, we don't pay any attention to that. So don't tell me that LAD is severely diseased, so I will stent it. I will not agree. That is not the correct answer. I want to know how much myocardium is ischemic. Just because LAD is disease severe 90%, it doesn't mean I have to stent it. I will stent it only if the amount of myocardium involved is beyond a certain limit. Got it?
Yes.
So the amount of myocardium at risk, to my eyes, it does not appear to be large because it occurred after a major diagonal. It occurred after two septals. So almost all the major branches of the LAD have taken off, and there is a good dominant RCA. Therefore, the distal septum probably is getting supplied by RCA from the posterior descending. I am not too worried about the apical part of the LAD. So to my eyes, eyeballing, rough impression, I feel that the amount of myocardium does not appear to be very large in this case. Moreover, this patient is 74-year-old. Here I have a complex lesion, LAD, long segment calcified, irregular lesion, and the diameter is reducing from 3.5 to 2.5. It's not a uniform diameter. So is it a simple angioplasty? Is it a complex angioplasty?
A complex.
That means the risk of complications is much higher. And therefore, in a nearly asymptomatic patient who is a low risk case, who is very well having a good lifestyle, who is easily being managed on medical treatment, I would be very hesitant to do angioplasty and stenting unless I have clear evidence of critical myocardial ischemia. You agree? Who advised PCI?
Oh.
Who advised PCI?
Yes,
huh?
yes.
Who advised PCI?
Sir, Nikhil, sir.
Okay, Nikhil. So now you agree that I don't think myocardium appears to be large, but okay, because you are arguing PCI, I want to be scientific now. Therefore, I need to measure the amount of myocardium at risk. How do I measure it? Now, there's many tests of ischemic, measure ischemic myocardium. Which one would you employ? Nikhil, come on.
Sir, specs we can do, sir.
Okay, why not treadmill?
Treadmill, sir, I mean, already it is able to tolerate, sir.
No. Treadmill does not give you any quantification of myocardium at risk. That is the answer.
Yes, sir. Yeah.
Yes. What about stress echocardiography? Yes. It can be
yes,
done,
sir, we can do, sir.
but it's also a semi-quantitative. It doesn't give you a number. No, below this is significant, below this is not significant, above this. It doesn't give you a specific number. It can be done. It is semi-quantitative because it depends on the number of segments which become dyskinetic.
Yes.
Okay. Perfusion scintigraphy is probably the best one, where you can assess the amount of myocardium which is ischemic on stress.
Yes.
Now, these are other studies which can be done. These are also very good tests, but they're all very complicated and they're all just evolving now. And therefore, at the moment, I think stress spect is the best test for achieving measuring total amount of ischemic myocardium. Nuclear PET study is excellent, but it cannot be done in every hospital. Similarly, newer CT angio measure with stress test can be done. There are CT machines with stress tests available, and there are MRI machines with stress perfusion study available now. But these are all very complex studies and not easy to do. At the moment, I think stress test with scintigraphy is probably the best one to quantify the useful. So treadmill is not useful in this thing. I think the test to do is quantitative stress scintigraphy. Okay?
Yes.
Okay. And the cutoff value, somebody said 12%. Okay, some people say 10%, some people say 15%. That's fine. Whatever number you believe. This, if it shows that less than 10% of the myocardium is ischemic, it is probably not significant. And this patient's SPECT showed that the amount of ischemia was 8%. And if it is more than 10, it is significant. If it is more than 15, it is critical or very significant, indicates ischemic myocardium. Therefore, with this LAD disease being in the mid-LAD beyond major branches, with a complex coronary lesion requiring coronary complex procedures, either CABG or rotablator stenting, I would do a quantification of ischemic myocardium, and I find that the amount of myocardium in the LAD territory and total myocardial at risk is less than 10%. Therefore, I conclude that the amount of ischemia is not critical. Am I right?
Yes, sir.
Yes, sir.
Okay. So now that is the final diagnosis now. You agree with that? Hypertension, smoker, non-diabetic, chronic stable angina, good effort tolerance, class 1, maybe class 2, 2-vessel disease, mid-LAD, significant type C lesion, mid-RCA, not significant type A, good LV function, and ischemic myocardium not too large, not critical, less than 10%. Yes? Now what is the plan? Now you have to decide. So the difference is you people started concluding right in one gentleman said conservative treatment at slide number 2. Another gentleman said PTC at slide number 7 or 8. I want you to be scientific, and I want you to answer in a scientific manner in the examination as well as in your life. I know sometimes we don't do all the tests because of economic reasons, I know that. But then we would waste a lot of money doing unnecessary tests. If you avoid all the unnecessary tests, then maybe in this case I could have avoided treadmill. I could have gone straight to coronary angio. Maybe that would have saved him some money. Like that, you should avoid some tests, but do the essential tests. And now is the time to answer this question. Will you do invasive? Invasive includes surgery and stenting or conservative therapy. Which one would you consider now? Hey, now why are you hesitating? What is the doubt now?
Conservative.
Conservative. Because you have to support your answer. No, never. Again, I always said one word answer is not appreciated. You must give the one word answer and follow it up with a reason. Then it sounds much better. Because my decision regarding invasive and conservative treatment depends upon the patient whether he is symptomatic or not. This patient is relatively asymptomatic, mild symptoms. Whether he is a stable, unstable angina or unstable angina. He is a chronic stable angina. And third one is what is the expected prognosis in this patient. Expected probability of major coronary events, MACE. So what is the expected prognosis? Hello?
May should be less than 2%, sir.
2% in what? 1 month or 2 months or 3 months or 10 years or 25 years?
5 years, sir.
Come on. 2% for 5 years, even you and me will not have. We will have more than that. A patient who has 2 vessel coronary arteries will have 2% in 5 years. Come on, don't be. You should make a guess, but you should not guess wildly. See, when in general in coronary artery disease, a low risk is considered less than 2%. 3%. 3%. Somewhere between 3 to 5 to 6% is considered as moderate. Anything more than 5% or 6% per year is considered as, is all per year, more severe. So just tell me whether you consider it a 3% bracket or 3 to 5% bracket or 5 to 15% bracket. That's all I want. Prognosis. Will his prognosis be same as a normal person?
No.
No. So he cannot be in the 2% category. Is he in the 10 to 15% category?
No, sir.
No, sir.
Not severe.
So what is the problem? Say he in the 5% category, moderate. Or
Moderate.
Low moderate. He's probably less than 5%.
Yes, sir.
Yeah, so it's a good prognosis. Less than 5% per year expected. What is the prognosis? I would say prognosis is very low rate of event. Not normal, not as much as a normal person, somewhere between 2 to 5% per year. So even if the LAD occludes, he is unlikely to be life-threatening. You agree with that? Yes, because myocardium risk is less than 8%. Therefore, even if the LAD occludes, it's unlikely that it will threaten his life.
Right.
Therefore, what is the plan now? And what about, why not do PCI for LAD to improve the prognosis? That is the other option. Why don't you do PCI? I told you some reason why we should not do, because it's complicated procedure. Any other reason?
PCI will improve only the symptoms, not the prognosis.
Yes. PCI is indicated for any coronary disease for that matter, only for symptomatic disease or for critical lesions like LMCA, proximal LAD, proximal 3-vessel disease, or coronary artery disease, LV dysfunction, or large area of critically ischemic myocardium. So does this patient fulfill that criteria?
No, sir.
No.
No, sir.
And on top of it, this lesion is a very complex lesion. It's a high risk coronary angioplasty with rotablator. Therefore, PCI is not the correct answer. And at this point, now you must not forget courage and ischemia trials. Don't quote it in the middle of the case. You remember courage and ischemia trials? What do they say? Hello? Okay, you go and read. These are two trials which you have to know and you have to remember. Both of them indicate that conservative treatment is no worse than invasive treatment in chronic stable angina. Okay? In chronic stable angina, invasive therapy does not give any advantage over conservative treatment if you have excluded these conditions. If you have excluded symptomatic disease, you have excluded critical lesions of LMCA, proximal LAD, proximal 3-vessel disease and all that, you have excluded LV dysfunction, you have excluded a large area of ischemic myocardium, then invasive therapy has no advantage over conservative therapy. Please go and read courage trials and ischemia trials.
Yes, sir.
Am I right or wrong? Somebody can correct me.
Sir. Yes, sir.
Okay. So please read it and tell me in the summary next time. Somebody should read and tell me. So now we come to the final slide, management. Now it is very easy. Come on, quickly enumerate, please. Come on.
Antiplatelet, sir.
Okay. Most important.
Sorry, sir. Yes.
Lifestyle, smoking, how much exercise he can do, diet, control of lipids. What is your target LDL in this case?
Less than 70.
70, okay. Okay, medication, aspirin, statin, lisinopril is already on. Would you like to add anything else?
Beta blocker, his heart rate was 56, sir, when we examined him.
Very good. I'm glad you are awake. I put that to see whether you are sleeping or not. So the patient's heart rate is already less than 60. So beta blockers have no use. What about calcium channel blockers? Hello?
Antihypertensive lisinopril.
No, calcium channel blockers are the same problem. No, that also will produce bradycardia. So you don't want to give that also. Okay. What about other drugs? Yes. Long-acting nitrates would you give?
Yes, so we can give, sir, long-acting.
Well, there's a controversy. Some people don't believe in long-acting nitrates. They only believe in as and when needed. But if you are a believer in that, you can add that. What about Ivabrad?
Again, heart rate is...
okay. What about ranolazine?
Ranolazine can be given, sir. But
you can give. Again, you are telling can be given.
Patient doesn't respond to nitrate, then ranolazine can be added.
I can also give another 250 medications. So can I give? Don't tell me can give. There is no role. If the patient is stable on 3 drugs, I don't want to add the 4th drug.
4th drug, yes, sir.
So don't give me can give answers.
Yes.
Okay. And very important, you have to tell him when to report to the doctor. And also you must tell him that he is not cured. This is very important. You must counsel him that you are not cured. You are only being controlled. Future events are definitely possible. As we said, it's somewhere around 3 to 5% per year. But even if events happen, we should be able to treat it. So this is also explaining the future is also part of your duty. Okay, don't tell him that you are all right, old boy, you are fine, go home, enjoy life. Don't tell him like that. Tell him that he has to be on lifelong follow-up, lifelong treatment and lifelong lifestyle modifications. Okay?
Yes, sir.
Yes, sir.
Right. And long-term, lifelong follow-up. So don't think a simple chronic stable angina cannot be kept for long case. We have been discussing a case of chronic stable angina for the last 1.5 hours. I can go on for another 1 hour also if you want. So you have to, and every question that I asked is nothing, no rocket science, no advanced cardiology. These are all basic day-to-day stuff. I don't want any high-flown fundas and high-flown papers being quoted here. But I want basic concepts of day-to-day cardiology very clear and very strong basis, foundation. This advanced papers and all is good to read, but only after your foundation is strong. Therefore, and in the examination, if I am the examiner, I will assess you only for your basic foundation. Okay? So please be prepared to answer questions on even chronic stable angina. Okay, it's almost already time, I think. I'll just quickly go through 2 or 3 spotters just for a change of taste. Okay, any questions on that? On coronary artery disease?
No, sir.
Sir, one last question.
No, you can ask as many questions.
He doesn't yes, sir. If he doesn't get relieved symptomatically,
okay, then
should we
take
think?
a plan. Yeah, definitely. See, symptoms are always this plan is only for today and as long as it remains stable. That's why I told you, you have to explain the future. We are not telling him this is the final decision. There's no final decision in coronary artery disease. The final decision comes only when he passes away for good. Till then, there is no final decision. This is the decision for now. And it is always subject to change if the clinical condition changes. If after 3 months he becomes unstable angina, we will treat it accordingly. If his symptoms trouble him too much, we will do angioplasty. If he develops one more lesion in the circumflex, we will do a bypass surgery. What is the problem? It doesn't mean that I have to do it now. Oh, you want to do it now for future events?
No, sir. No, sir.
Yeah. So we are not ruling out future change of plans. We are only telling him now and for the next few months, we don't want to do anything more than medical treatment. That is the best for you. We can do a lot of things. I am quite capable of doing angioplasty. I can do your rotablator. I can do your multiple stenting also. No problem. I am the best interventionalist in the whole world. But I prefer that for you, medicines are better than stents. That is what you should tell him. Got it?
Yes, sir.
Okay.
Yes, sir.
Okay. 2 or 3 quick spotters. Let's go. Who wants to take this? There are two slides. One is main pulmonary artery, one is aorta. At a scale of 100. I know you can't get one specific diagnosis. Just think of the possibilities, that's all. Describe the pressure, then you can go to the diagnosis. No takers? Okay, I'll give you a clue. What does the aortic pressure show? Start describing the systolic pressure, diastolic pressure, mean pressure. Start describing, no?
Wide.
I'm not hearing you. What is wide what?
So there's a wide pulse pressure of the aorta, sir. With systolic of 100 mm Hg and diastolic of around 40.
40, okay.
And by main pulmonary artery, systolic of around 65-70 with diastolic of around 35 to 40. So there's equalization of diastolic pressures in both the pulmonary artery and the aorta.
Okay. So, what are the possibilities?
PDA.
Okay, so you should start talking, no? Because it's very easy. Aortic runoff condition. Yeah. Aortic runoff condition with mild or moderate pulmonary hypertension. What are the possibilities? That's all I want. A patent ductus arteriosus is very likely. Is it a very large patent ductus arteriosus, a small patent ductus arteriosus, a moderate patent ductus arteriosus? Which one would you prefer?
Moderate, sir.
Moderate. Because why?
Because pulmonary artery pressure is still lower than the aortic pressure, so there's no equalization of this.
Exactly. So because the shunt is not very small, but it's also not very large. Pulse pressure is about 60 or so. That's not very wide. Similarly, PA pressure is elevated, but not as much as aortic pressure. So the PDA cannot be very large. At the same time, it cannot be very small. Moderate size. Okay. Any other condition can fit in? Any other aortic runoff can fit in with? What other aortic runoff do you know?
RSOV.
Okay. RSOV.
AP window.
AP
window.
Okay. So, which one would you stronger? AP window or RSO? Which one do you want to consider first? Before the other. You have to say in the order of probability, no? Do you think AP window is likely? See, AP window, the name is window. It is not a tube. That means it invariably there is equalization of aortic and PA systolic pressures. A window means it's a wide, big opening. Have you? No, you don't have a window which is pinhole, no? The name window means what? It's a sizable opening and there is no length. The window has no length. It's a short opening. Therefore, there is no drop in pressure from aorta to PA. So, although aortic runoff may be present in a AP window, this is unlikely to be AP window because there is no equalization of systolic pressures. The AP window is not likely. Third one you said was RSOV. Is that possible? RSOV is possible, yes. But then again, RSOV would have a torrential shunt, whereas RSOV commonly open. But with RA or into RV, both are low pressure chambers, isn't it? Somebody's mic is making too much noise. Can you check whose mic it is? Okay, so RSOB produces torrential shunt, always. No? RSOB into RV, iota to RV EDP is only 10 or 12, therefore torrential shunt. And again, RA pressure is only 8 or 10, torrential shunt. Do you think this is suggestive of that? Not likely. Again, RSOBs generally have a much larger shunt. This does not suggest a very large shunt. The pulse pressure is only about 60, 40 to 100, only about 60 millimeters of mercury. Normal is 30 to 50, isn't it? Pulse pressure. 60 is just above normal. So it does not suggest a very large shunt. Therefore, RSOB is also unlikely. So I think, okay, RSOB AP window can be discussed as differential diagnosis, but most likely it has a ductus, because ductus is the one which has a drop in pressure from iota to PA, because the PDA has a length. The length will cause a drop in the pressure. Okay? Okay, I'll go to the next one. Who wants to take this? Come on, that's enough, man. Don't take too much time. They're all spotters. Any takers? Okay, start. What chamber is it? You're not. See, I have told you, even if you don't know the answer, start describing the slide. Nobody is starting that. At least describe. What are the features you can make out? At least those things you should describe, no?
The left side is the LV tracing, sir.
Why do you say LV? I know it is written there, but why do you say LV? I mean, why do you say ventricle at all, for that matter?
So because the diastolic phase, there's actually an upslope, sir. If it's arterial tracing, it won't be like that.
Okay, good. So it is a tracing and it's marked LV. So
it's a ventricular tracing. Yeah, so yes, it's and LV systolic pressure is around 50, and LV EDP is around 10, sir. Okay. And the right side tracing is RV tracing. It's marked there. RV systolic pressure is around 90, and EDP is around 10, nearly in between 10 to 15, so nearly 10, 12 around.
Okay.
10.
Good.
So here RV is suprasystemic, sir.
Okay. So what is the probable diagnosis?
So this can be some pre-tricuspid shunt, or it can be
pre-tricuspid shunt. I mean ASD, you mean?
ASD.
Okay.
Or it can be situations such as pulmonary stenosis with intact IVS, where RV can be suprasystemic.
Okay. Okay. So for one you have said pulmonary hypertension in ASD. Secondly, you have said pulmonary stenosis with intact ventricular septum. Okay. Any other differential diagnosis?
TGA.
Okay.
TGA, sir. TGA.
No, wait, let her finish. I'm asking her the third differential diagnosis. Okay. What is your comment on ASD, PAH and pulmonary stenosis intact septum? Is that possible?
Sir, I didn't get it, sir.
No. So, do you think in a case of severe pulmonary stenosis or in case of severe pulmonary hypertension, I can understand RV pressure being 100. That I can understand.
Yes, sir.
But how will LV pressure be 50 or 40? You think that's compatible with life?
No, sir.
Then, so you're making a diagnosis which is incompatible with life. What is the definition of suprasystemic pressure?
Above aortic systolic pressure, sir.
Okay. What is the aortic pressure in this case?
Oh, 50.
So I told the patient won't be alive with a pressure of 50.
50. Correct.
So how can he have cath when he cannot be alive? Yes, somebody else was talking there.
So here RV is the systemic ventricle, sir. LV is the...
So what is the aortic pressure?
100, sir.
And what is the LV supplying?
LV is supplying the pulmonary circulation.
So what is the diagnosis?
TGS, sir.
That's all I wanted. So any other information you can give me from this tracing?
Sir, here the trace was taken on a single catheter, sir.
Okay.
Is it looking like a pullback catheter, sir?
Okay.
Pullback trace.
So what does it indicate?
There is a communication between LV and RV, sir.
Okay.
Maybe top with restrictive VSD that is causing RV pressures higher than LV, sir.
You mean tetralogy will have aortic pressure of 50?
Sir, restrictive VSD, if it is...
Even restrictive VSD, you mean aortic pressure will be 50?
Here aortic pressure is not mentioned, sir. It is only RV pressure.
You think a patient will be alive with a pressure of 50? Don't make impossible diagnosis, no? A patient cannot be alive and having cardiac cath with a systolic pressure of 50. Is that possible?
Not
yes or
possible, sir.
Then why are you saying that? So here the RV is a systemic ventricle, aorta is coming from the right ventricle, and LV is connected to pulmonary artery, and LV is giving pulmonary pressures. So LV systolic pressure is 40, which is PA systolic pressure, and RV is connected to aorta, therefore RV is showing aortic systolic pressure. Aortic systolic pressure is 90. That is compatible with life. Am I right?
Yes, sir.
Okay. Any other conclusion you can draw from this tracing?
So that the diastolic pressures of LV and RV are almost the same, sir.
So what? What does it mean? Does it mean anything?
Yes.
What?
Maybe LV is failing, sir, here. That's why the diastolic pressures are elevated.
No. I don't think that means anything. Both are in the range of 8 to 10, both are normal, 8 to 12, both are normal. But it is a continuous tracing from LV to RV. Didn't you see that?
Yes,
what
sir.
does it mean?
Between LV and RV, sir.
So what is it called?
This is a VSD.
Ventricular septum.
Why don't you say that? So this is a transposition with VSD. Yes or no?
Yes, sir.
Yes, sir.
Okay. Any other information you can give me?
Restrictive VSD.
Very good. Because the LV pressure and RV pressure are so different, the VSD must be very small. Okay. Now, with each sentence, we are improving our diagnosis. So now we are getting transposition, then we got a VSD, and now we are getting a restrictive VSD. Any more information you can give me? I always told you, whenever I show you a congenital heart disease, you must think of associated lesions. So what is the most common associated lesion in transposition? What is the most common lesion?
ASD.
VSD. Okay, ASD is always there. No, ASD is not considered associated lesion. It is part of transposition. VSD is the most common lesion. That we have already diagnosed. What is the second most common lesion?
Pulmonary stenosis.
Very good. Pulmonary stenosis. So does he have pulmonary stenosis?
Not significant, sir.
Not significant.
Because RV systolic pressure is around 50.
Hey, RV. Again, you are telling RV.
Sorry, LV. Sir.
Yeah, LV systolic pressure only 40 to 50. Therefore, pulmonary stenosis is not there, or if it is there, it is very mild. Okay? So there's so much information in this figure. Unless you diagnose, from this figure I can diagnose is a transposition with a small restrictive VSD and there is no significant pulmonary stenosis. Okay, one more question. What do you think this patient's aortic saturation will be? Cannot take that long. You cannot take this much time. I'm telling you, I am having too much of patience. The examiners won't have this much patience.
The pulmonary stenosis is very mild. Pulmonary stenosis is mild. So
my question is, what is the aortic saturation? Please answer that and then give me reasons.
Say around 70-75%.
Okay, that's all I wanted. Aortic saturation will be desaturated. That's all I want. It will be low. Okay? What will be the pulmonary saturation? Pulmonary artery saturation?
More than 95.
Okay. This is one of the very few conditions where PA saturation is higher than aortic saturation. It will not be 95 because there will be desaturation at the atrial level, but it will be somewhere 85 to 90%. So this is one of the very few conditions where PA saturation will be higher than aortic saturation. Okay. I think last one, I think. Is that the last one? Yes, that's the last one. Very simple one. Don't take much time. I've taken it from a book, I think. Yeah, who is taking this? All those four guys who gave the names in the beginning, did they answer questions? I heard...
yes, sir, we are here only, sir.
Yeah, I heard Mihir's voice. I heard Rufus answered in between. Saurabh, did you answer anything?
Sir, I was there, sir.
Yeah. And Kashyap?
Yes, sir.
Okay, why don't one of you take it? Kashyap, come on, take this.
Simultaneous pullback pressure tracing with first one is the ventricular pressure tracing, left ventricle.
Okay.
Is 200, around 30 millimeter mercury. Then there is aortic pressure tracing, sir, with systolic and there is pressure gradient between LV and aorta. Aortic systolic pressure is around 160 and diastolic is around 60 millimeter mercury. So there is aortic stenosis with aortic regurgitation is there, sir, because of wide pulse pressure and pressure gradient between LV and aorta.
Over?
Sir, and the aortic stenosis is not severe, mild or moderate, because gradient is around 40 millimeter of mercury.
Give me your final diagnosis, please.
Yes, sir. This mild aortic stenosis with severe aortic regurgitation.
It's always customary to say the severe lesion first. Don't say the mild lesion first.
Yes, sir.
You should have some order.
Yes, sir.
So severe AR, mild AS. Then anything more? That's all. Okay. Anybody want to add anything to that?
Sir, no associated mitral valve disease.
Okay. What else? Anything else you want to add?
Elevated LV end diastolic pressure is there, sir. So patient
How much? 20, okay, 24, okay. So anything